Ladies and gentlemen, welcome to the Beautifully Broken podcast. We are joined with my good friend, Dr. B. Welcome to the show, Anil. How
Yeah.
you doing?
Good. Thank you for having me, Freddie. Good to see you.
It's good to see you. I see you all over the world at all these events, and you truly are with the movers and shakers. How do you serve the world in the way of wellness? What do you do?
That's a loaded question because it kind of stems from my passion for the biological life sciences. That started as a teenager, but by training, I'm a family physician with additional integrations for functional medicine. I studied with the IFM and the A4M. I teach at George Washington University, and that kind of led me to kind of carving out my own narrative based on what I teach at the university, what I do here in the clinical practice in the field of precision medicine, using multiomics in clinical practice. And I'm also really into the same technologies that you're into, with all the different really fascinating gizmos and gadgets from around the world, from New Zealand to Germany and everywhere in between. There's some really interesting tech that's coming out that I like to leverage here in my private practice for my patients to have access, so that we could explore some of these different healing modalities, because I don't think you're going to heal from a pill, just generally speaking. We need some different toys and technologies that actually move the energy and, restore the charge and stimulate the mitochondria and mobilize the lymph and, get things open and circulating and the flow moving again. So
Yeah.
I have a whole side of the practice I would call longevity gyms, which is basically all those fun toys.
Yeah, they're so fun. God, it'd be so easy to talk to you about all the tech that you love, because it's like a kid in a candy store for me. I love it, especially when things really, really move the needle.
Yeah.
I just want to say how lucky Maryland is, the Maryland area, to have you,
Oh,
because
thank you.
in different areas of the world, it can be like a desert to find access to some of these things. When people have called me on consultations and I'm like, oh, maybe you can get over this guy. But really, knowing you and knowing all that you offer, it really is, you kind of have everything from the regenerative medicine to the multi-omic sciences to be able to do great diagnostic work. How has this evolved over time? Obviously, you did not start here.
Yeah, no, it's just really interesting because it's like, I think as a science has evolved, my undergraduate degree is in molecular microbiology and medical laboratory science. And, what started off as a passion for using dark field phase contrast microscopy based on, I think, our common teacher, Dr. Thomas Rau, from Switzerland and Germany, and how they're using it clinically to look at undenatured peripheral blood under the microscope to get a qualitative cellular dynamic appreciation of what's going on in the milieu, has led me down a road of, looking at how we connect those molecular dots from genome to phenome. And so that background in molecular microbiology and medical laboratory science prior to starting medical school, and studying all the natural stuff before medical school, from, dare I say, clinical homeopathy, that actually is accredited by the AMA, right, to get those credits. It's validated kind of clinical homeopathy for any of the critics out there. Herbal medicine with the ABC and Mark Blumenthal, looking at medical acupuncture at University of Miami. I've, spent so much time, studying these integrative modalities prior to med school. And then when you get into medical school, it's, I hate to say it, but, the information that you learn by the time you graduate, more than 50% of it's outdated. There's research out there, I think it's Nature publications, that demonstrated that there's a doubling of medical knowledge every 78 days, and that's really hard for physicians to kind of stay abreast with all the emerging science, research, and technologies. And, once you leave training, it's like up to you to stay within the appropriate networks to continue that medical education, to keep up with best practice within the industry. And if you niche down and subspecialize, whether you're a cardiologist or endocrinologist, gastroenterologist, whatever it is, it's also further complicated to kind of look at, certain aspects of what's emerging in the field and the research that's constantly growing. So for me, it's the conversation has personally evolved from what I teach at the university. I essentially teach the entire American Academy for Anti-Aging Medicine Fellowship through A4M at George Washington University with the classes that I teach. But there's one class that I'm very particularly excited about that I've been teaching for a few years now called INTM 6205, the Omics of Medicine. And it's like I teach other doctors how to connect those molecular dots from genome to phenome and how to make sense of that from a translational process. And that kind of gave rise to how I practice medicine because, we've all been to the functional medicine conferences and it's fantastic. It has a very, root cause, integrated, holistic approach, systemized approach to addressing somebody based on, ATMs, which are, antecedents, triggers, and mediators, using a timeline, using a functional medicine matrix, connecting all those interconnected values. But how do we take that a step further at refining, I would say the molecular kind of phenotype to that narrative and really, structuring it even further with like using some of the different diagnostic testing that's being endorsed by functional medicine practitioners, like microbiome analysis, environmental toxin testing, metabolomic profiling or OAT testing, advanced biomarker analysis, and so forth. So for me, and genomic medicine, right? And the different applications of genetics, right? So there's a difference between genetics and genomics, and, genetics, traditionally refers to those inborn errors of metabolism, more of a classical Mendelian approach to like, disease obscurities, and looking at conditions like PKU and cystic fibrosis and things like that. Versus genomics, looking at the totality of, an individual's instruction manual, their book of life, right? That has 23 chapters, 23 chromosomes, half written by their biological mother, the other half their biological father, and using that information to kind of dive into these theoretical predispositions. And I also, mention to folks that, hey, your DNA is not your destiny. We use this as a roadmap clinically to just understand the deck of cards you've been dealt with and where we need to pay attention to when we look under the hood. Whether it's through proteomic or metabolomic profiling, imaging, advanced imaging, whatever it is, it's connecting those dots into a cohesive manner to get a better appreciation of what's going on. Now, for you and I, we know that there's limitations to this, kind of assessment, right? That kind of stops at a certain degree. And I think some of the things that aren't brought into a precision medicine approach, molecular kind of multi-omic approach, is I would say, dare I say, the quantum associations, the thoughts, words, actions, behaviors, the psycho-emotional triggers, factors that influence, our autonomic nervous system, our ability to, let go or hold on to an emotion and that trauma and how that influences somebody's, disease process. So I think that's one of the limitations to that kind of profiling, but it's not to say you can't unpack it as a clinician. So yeah, it's just really interesting stuff. I have fun with all of this. I tell everybody, look, the promise of precision medicine begins with your story, and everybody's story is different. Their evolution is different. There's really interesting evidence about transgenerational epigenetic programming, looking at how, trauma of generations past influence us today. Me being Indian dude, we have different genetics, right? That predisposes us towards cardiometabolic issues. Indians are the worst with that, unfortunately. And it has to deal with, our evolutionary biology and looking at, times of scarcity and famine that, influenced our phenotype, and predisposition towards, triaging of energy. So I could go into all sorts of stuff, but yeah, that's.
Yeah, we could. We'll probably have to do like 5 episodes here. Hold on one second. I got to change one setting on my recording. Hold on. I'm going to pause. All right. I just wanted to do a little setting on my sound optimization here because I'm an audiophile. The scope of work you bring to the practice, again, it's just because I know you and I see you're always training, you're always doing continued education. When we look at the field right now and we say the omics sciences, Can you describe that for the layperson that's coming into your office? It's like,
Yeah.
let me ask you this. How do you meet people when they come in off the street and they're like, here's my issue. I want to feel better. How do you bridge all your knowledge and put it into a packet where they can embrace it and understand what you're doing?
Yeah, and I think it just depends on, their kind of their story and their symptomatic profile and everything else, because you could even just start with, like, their core set of symptoms, or kind of their medical health, past medical history, and kind of where they're at that given moment in time. But I explain to everybody, if, you're coming into my practice, one of the, I think, unique aspects about myself clinically is that I'm one of the few doctors that try to really take that deep dive into the translational applications of multiomics. And to answer your question about what that means, multiomics refers to the different molecular layers and independent studies of biology. So the study of genomics is the study of your genes and your DNA, right? The study of the transcriptome looks at RNA expression and how certain genes are upregulated or downregulated based on various environmental signaling and inputs and so forth on gene expression. I look at the epigenome in the context of aging and cancer, right? And that has another environmental gene interface factor here. And looking at methylation and deacetylation and these different signatures that could be associated with pathology. I look at proteomics, which are the study of proteins, right? And proteins are essentially advanced biomarker analysis, and we can identify molecular signatures of, I would say, some core perturbations in the system or shifts in the system associated with inflammation, oxidation, ischemia, and immune dysregulation are some of the core things that we see here, right? So, identifying those signatures on a proteomic level and a metabolomic level. And metabolomics refers to looking at how proteins give rise to enzymes, enzymes give rise to metabolism, and metabolism is function. Sometimes things don't function right, whether it's a mitochondria, the, Golgi apparatus, or ribosomes, or whatever it is. And we have the ability to identify certain signatures associated with disturbances on a metabolomic level, right? I like to look at the microbiome, which is the amount of it refers to the amount of microbes that we have, on our skin, in our mouth, in our stool, right? I think before we started recording, we were going over looking at an oral microbiome analysis. It's very interesting. There's companies like Oral DNA out, or you could just take a swab and look at it under the microscope and identify these different pathogenic microorganisms like Treponema denticola, which is associated with, like, Alzheimer's. It's very interesting. So the microbiome also plays a very important role in understanding that we're outnumbered by an order of magnitude in bacteria than we have actually eukaryotic self cells. This is fascinating. And then I like to look at the exposome. The exposome is very interesting. I'm actually a part of the Human Exposome Project, which is a new initiative that was launched a few weeks ago here in DC on behalf of the NIH and Johns Hopkins and multiple different stakeholders across the world. And it's kind of piggybacking off of where the Human Genome Project left off nearly 25 years ago, looking at how the environment influences our gene expression, influences how, that predisposes us towards different diseases and conditions. So, when you really look at that, like, that bioaccumulated toxic load on our system can be coming from all sorts of stuff, man. I'm sure we can, we live in a toxic world, right? From the air, water, food, all that stuff that we come into contact with, to our bubble, so to speak. Some people, unfortunately, are genetically predisposed towards impaired cytochrome P450 detoxification pathways. They might have also impaired glutathione recycling. They might have impaired, other signaling pathways that leads to this bioaccumulation, not just genetically, but let's say, hey, you're sitting down all day, you're not moving your lymph, you're not sweating, you're not exercising. That plays a role. You're not eating good food and fruits and vegetables to, boost NRF2 signaling. That plays a role. All those different confounding variables influences how your body is going to respond to the world around it. And, they say your DNA is marked by, experience. And, we carry with us a memory of all these different historical exposures potentially. And as we bioaccumulate that stuff, that toxic load, so to speak, that actually has the
Mm.
ability to lead to DNA damage, right? And some people
Yeah.
have TP53, P53, polymorphisms that influence their, kind of base repair mechanisms and DNA repair. It might influence their ability to accumulate what's called DNA adducts and DNA damage, right, within the system. We measure that stuff, right? And
Yeah.
we look at, all of that put together is honestly, I think needs to be what every doctor does. Going to your doctor and doing a 15-minute visit once a year is bullshit, right? We need to go in there and like take a deeper dive, do, I call it deep molecular phenotyping of the individual to get a better understanding of what the hell's going on, right? Once we know, we're like, all right, this is your baseline, all right? And this is where we're at right now. And you have the ability to make conscious decisions about diet, exercise, lifestyle, nutrition, sleep, and relationships, and all that stuff to basically make meaningful deposits into what we call your biological 401k. I think you're good friends with my good friend, Dr. Jeff Drobot in Arizona with the Biomed Center. Love Drobot. Known him for almost 20 years now, and we
Yeah.
both have a similar analogy that we have. He calls it, what is it, age accounting. I call it biological 401k, but it's the same concept that, we have this internal biological health savings account for which we're making daily deposits of withdrawals from, right? In different forms of epigenetic and currency, right? And,
Yeah.
and we have the ability to make meaningful deposits into our health so that we could save for retirement and have the ROI, which is going to be health span over a lifespan, and once we have, that kind of, accumulated kind of resilience, that's just going to help with the, graceful aging process. I'm not going to call it anti-aging, longevity, even though, Drobot wrote the foreword to my book and my book's coming out, The Longevity Equation. I chose this title before longevity became what it is today. I think a huge fad and whatnot, but that's a whole nother conversation.
I like it. I think you can reclaim a word, and it's really, again, the title, the name, whether it's biohacking or longevity or health optimization. I equally, I get burned out from the word. I was like, I want a different word than that. But the reality is, it's like what's inside that book and all the things that you're talking about that you're bringing to the table in practice.
Correct.
It's not just a title of a book. So I really like that. I also would say that I want to ask you when we're talking about all these different ways to look at a person and do a diagnostic deep dive, what percentage do you think the lifestyle factor plays into outcome in somebody who walks into your clinic, be it the movement, lifting weights, sleep hygiene, dedicated to clean eating, some type of a mental flossing or mental health practice, time and meditation?
It's interesting. I think that has a tremendous impact on your biological expression or health and resiliency.
Mm-hmm.
But I've also had patients that have done that and they eat super clean. They, filter their water, RO, trace minerals added, everything's organic. Their sleep is dialed in, their HRV, their meditation, their exercise, and they still have issues, right? And so it's really hard to pinpoint and say, in a generalized population based kind of application, who, what, and how, because I think everything boils down to N of one. So everybody is at the core of their own biological study, and their blueprint is completely different than mine or someone else's. And despite, good actions, behaviors, and everything else being dialed in, I've seen some very unfortunate stories, and it's tough to see. But then you got, somebody that's like, hey man, I've been smoking and drinking aggressively for a while, and I, do some questionable things, and their resiliency is out of this world. And I'm just like, is it a mindset issue?
Mm.
Where, I've met all these like super anal retentive biohackers that need to do all sorts of weird shit in order to get into their whatever flow state, whatever that is to them. And it's just like, all right, the second something doesn't go their way, they crash and burn. So is that really
Hmm.
resilient? Because, whatever, if I, like even like I have these glasses on right now just because I'm in front of the computer screen all
Yeah.
friggin' day, so trying to, mute some of those, those stressors on my cones and rods is the goal of trying to mitigating those stresses and being cognizant of the different biological exposures to the environmental factors leading to that allostatic load or stress burden on the system. So, it's weird. I don't think I answered your question, but I think everything you mentioned is like super hypercritical in everybody's state. But at the same time, when it becomes like all consuming, and if you want to go out with your friends and have a beer one night at a concert, but you're afraid it's going to,
Yeah.
F up your routine, like that's not life, dude, And when you
Yeah.
see, I'm not going to name anybody specifically, but I think the type of person we're speaking about that's so hypercritical on their whatever it is that is to me, you know, I think health is not necessarily the absence of disease, but the body's ability to adapt to a stressful situation, right? And
Yeah.
be able to withstand, different stressors and still be able to perform and have some sort of biological reserve and resiliency, right? So, you know,
Yeah.
for me,
Amen.
like, so yeah, I've worked the night shift multiple times. It sucked. I hated it. Really effed me up, but you still have to make rounds, at 7 a.m. and be prepared to, pull a, all nighter, and you're up for 36, 40 hours at a time and still have to perform cognitively for your patients. Right. So it's just, food. Sometimes you don't get to eat when you're, in
Yeah.
certain clinical settings, and that sucks. And you gotta push through somehow. So there's, I don't know, man. It just, I think it's sometimes a mindset and whatnot. And I think at the end of the day, it's all about balance, right? Maybe as generic as that sounds, being able to make those meaningful deposits with diet, exercise, sleep, nutrition, mindfulness, relationships, and so forth. When you have the ability to kind of recharge your battery and unplug from all the stresses. And then, I say, play hard too. Go out and have fun, right? Because you
Yeah.
go to the conferences, you see some of these folks who are like, "Oh, I got to be in bed by 8." It's like, why not? Let's go have fun. Let's go, like, some of the
Yeah.
best meaningful conversations comes out around, midnight, 2 a.m. at these conferences with our friends and colleagues in the space, and a lot of meaningful things happen. Um,
Yeah.
Not saying do that every night, but I don't know. Just a thought.
No, it's a great thought. It's a great reminder. I also wonder, because you're who you are and because you have the skill set that you do, that the outliers who are needing high level expertise, insight, and they need to break apart those multi-omic sciences and they need the high level diagnostics, that they're coming to you because you can do that for them.
Oh yeah,
Do you know what I mean?
sure.
I always want same thing. It's like my inbox is filled mostly when people reach out. They're like, "Hey, I've got MS. I've got lesions on my brain. I've got stage 4 cancer. I've got, because of what I went through."
Hmm.
That's what's magnetized to me. So I'm facilitating that person onto a qualified practitioner or clinic, and that's just, so I realize that that's not everybody, so I can easily establish this bias. I'd be like, oh my god, it's so hard to get better. Well, not for everybody. Some people, it's like, they cut out gluten and and they like
Yeah,
slap on some blue blockers and they're like, oh my god, I dropped 25 pounds and I feel amazing.
yeah,
And
yeah,
I'm like,
yeah,
you should see. Yeah. And I'm like, oh my God, if you saw my sleep hygiene protocol, for most people, it'd be ridiculous. But even if I don't sleep, I wake up, if I don't sleep amazing or the score isn't amazing, I still feel pretty great. I've got my little peptide stack. I did a little biofeedback before we got on the interview this morning. I got my caffeine-free my paraxanthine coffee. So I didn't do a lot, but I got a couple things. I also stepped outside and took my outdoor shower in the morning light, just to ground and like be outside and get some fresh air. Hugged on my puppy a little bit. There's things, but I'm very joyful in the morning. Like, I have a routine that works for me. Some things are very biohacky. Some things are just super, get outside and be naked in my backyard.
yeah, yeah. No, and I think there's something to be said about that connection, to earth and the grounding element to all of this. One of my patients, he's actually one of the guys that was really involved with NIH studies around grounding and has
Hmm.
multiple publications associated with it. And so we've had very extensive conversations around, how that influences the body's charge and frequency. So, and
Yeah.
I think, the term biohacking is very well intentioned in regards to how we can kind of help augment and shape the biology within, by meaningful, kind of intentional habits and routines. And it's very interesting, for me, like and the biggest thing is it's like, how do you not create fear, and provoke anxiety in folks when we have this level of data, regarding whatever it may be. And, how do you, I mean, even full body MRIs comes with it a huge, kind of argued risk, so most conventional MDs will say, that's unnecessary. It's going to lead to unnecessary kind of priming and provocation and health anxiety and so forth. But it could also save a life, so it depends on who the person is, right? If somebody comes in and they're super anxious to begin with, it's you got to be careful, offering some of these certain things. Even genetic testing, when you got a polygenic risk score associated with an increased risk of colon cancer, and there's a family history of colon cancer, how do we work on shifting that ecosystem of the gut, preventatively,
Mm.
functionally, to mitigate any potential, damage accumulation? How do you monitor it beyond a colonoscopy, to get a better
Mm.
surveillance and kind of longitudinal, dare I say, health optimization of the terrain of the gut, right?
Yeah.
That's a whole nother conversation and deep dive in regards to microbiome shift and looking at the gut physiology and ruling out, any micronutrient deficiencies, short chain fatty acids within the colonocytes needed for healthy, terrain of the digestive system. So, with all that being said, and I could tell you stories all day long. I had a patient who had a history of pancreatic cancer and a couple of other cancers. I just want to be mindful of their story. 66 years old, and comes back, and they had polygenic risk scores associated with all sorts of bad things. They had, they came back in with metabolomic profiles associated with increased DNA damage with 8-OHDG. They had lipid peroxidation. Also microscopically, the cells were demonstrating signs of lipid peroxidation or poikilocytes, spiky red blood cells,
Hmm.
microscopically, which is a sign of oxidative stress. So, there was genotoxicity and cytotoxicity that were identified. There was malabsorption patterns, or all those things metabolomically, proteomically, inflammatory markers through the roof, microbiomically, multiple drug-resistant dysbiotic organisms with, signs of EPI, exocrine pancreatic insufficiency, short chain fatty acid deficiency, all sorts of stuff, because of, what he's been through, to save his life and get him acutely medically stabilized. And then you run the exposome test. I do this all the time. And it's like, oh my goodness, look at the amount of glyphosate in the system. The organophosphates are bioaccumulating. And it's just like, they're like, oh, we eat organic. Yeah, but you golf, and that golfing, it's aerosolized and you're huffing that down. And look at how high it is in the system.
Mm.
And I'm sure you saw that study that came out about living within a certain mile radius, 1.5 to 3 miles of a golf course, and the increased risk for Parkinsonism, right? Or
I have a very close family member. We were talking about this. They moved down to Florida, to retire, and they got a spot on a golf
yeah,
course. And that study was probably started making the rounds on the social media platforms 3 weeks ago, and just blah 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 is having these memory issues, and he golfs every day, and do you think there's any possibility? I was like, well, you do live on the course, it's something to definitely consider. Now, what do you do with that information, right? I
that's
think we're
exactly it.
What do you do with that information? And it wouldn't, honestly, it's like, okay, well, if you're gonna live there, then I want to support the liver. I want you to be sweating. I want you to really focus on hydration. I'd love at least the groundwater that you got, hopefully not from the tap in Florida. Maybe we can upgrade that. There's things that I think where you're at in life, also your income, what you're willing to do, what you're willing to commit to every day. But yeah, they wouldn't change massively unless I'm gonna put them on a plane and fly them up to you.
Yeah. Well,
Because there's also, I will say this, with a lot of these tests that are coming out right now, and you can have, like, again, the big influencer podcasts where, like, oh, look at what we found in this person's tissue. And then directly after that is the sentence in which they're shilling their, like, 4 drops of a supplement that will completely detoxify you, which you and I both know is not valid. It's not going to be from 4 drops of one bottle. This is a systemic thing. It's a lifestyle thing. There's a lot involved. But what do you do with that data?
yeah, yeah. Well, and that's the thing. Everybody's data is different, right? There's different stress points, within the system that we need to kind of prioritize and pay attention to. And again, starting off with connecting those molecular dots and seeing where, the greatest threats to your longevity are based on, those profiles. And it ultimately, especially like, in a scenario like that where malabsorption is playing a very important role and there's digestive issues due to that pancreatic, issue that person had, and other cancer that he had, status post, chemo therapy and everything else. It's like, we got to be gentle, right? You don't want to go in there and
Yeah.
stir the pot too much, but we definitely have to, number one, mitigate exposure, right? And then we have and this person's very affluent. They have access to, saunas, hyperbarics in their home and everything else. And, it's you kind of have to start repleting, I think, some of the micronutrient deficiencies that are there. You got to start removing those obstacles to cure and making sure that you're mitigating ongoing exposure to the things that are accumulating in the system. Mercury is there, so I'm trying to get him plugged into our friend Gene here at the Julian Center in Columbia, Maryland for biological dentistry, because there's several silver fillings, in our training that you and I have gone through with the Paracelsus Clinic and based out of Switzerland. They basically, or with Dr. Thomas Rao Network, they recommend starting in the mouth. So, we got to start in the mouth. We got to address any root canals and, kind of amalgam fillings that could be leading to a distortive foci or focal area biological interference. And then start peeling back the layers with, if you're malabsorption, giving somebody a bunch of oral supplements is probably not going to work as well as, acutely teeing up very targeted micronutrients in an intravenous delivery system. And then, working on like the dysbiosis for the supplementation makes more sense, right? To start the gut healing process. And then, like how do you start, infusing, gentle daily detox things, like exercise, run, box, jump rope, rebound, trampoline, flow presso, right? Sauna, right?
Yeah.
Into a routine. So it's not too hyper-stimulating for somebody to have a huge, dump and mobilization of biotoxin from the system, but enough to begin the, detoxification process. EBU, ozone, therapeutic plasmapheresis, right? Or an exchange, TPE. And use pheresis, which is about to come over to the U.S. from Germany. Those types of modalities to go in there and pull out all the stuff, right? And then how do you unlock the regenerative potential? In our office, we're using a few different regenerative modalities, including autologous stem cell therapy, right? V-cell therapy. We're using some photobiomodulated plasma therapies as well, to kind of stimulate the body's internal healing response. And the best thing is it's self tissue, so if there's any, questions about donor tissue, we don't have to do donor tissue. We don't have to do donor stem cells. We don't have to do that. So we could use good peptides, and these photobiomodulated plasma therapies to go in there and help that regenerative capacity. So again, I think there's a therapeutic order, and again, it's just my opinion, and thought process after studying this field since I was a teenager. I started off working with supplements when I was 16 years old at Whole Foods, back when, all the large supplement folks would come to the store. Michael Murray, who wrote the freaking encyclopedia of natural medicine, came and met him a bunch of times and, heard him speak. And, so I was influenced by some very interesting things at a young age.
Yeah.
So
it's so cool.
It's the art of medicine, it's the art of medicine. with it.
Yeah, walk us back to we right at the beginning of the interview, we kind of touched on dark field microscopy, which I know. Tell me where that sits as far as a regulatory boat in the U.S. Is that where because I hear if you look up, and now I've done this with practitioners, it's been really amazing, and it was in the midst of horrible mold exposure. We could actually go in, and he showed me somebody else's blood. He goes, now let's look at yours. Look at some of the lipid layers of the cells, and they were all kind of bumpy and crunchy and dried out. He's like, this is damp. This is from the mold. Here's what good blood looks like. And then the other thing they were able to show me is he's like, he could show me spiral bacteria
Mhm.
floating around in the blood because I had an active Lyme infection.
Mhm.
Now what we do with that information, I was symptomatic. It was a really interesting way to look at the body,
Mhm.
but I know some people reject that as a science online or a viable diagnostic tool. Where does that sit in the regulatory space?
Well, and I agree that it should be rejected. Because there are a lot of people out there making bullshit claims, right? I can tell you
Yeah.
now, I've been doing this for almost 22 years,
Mm-hmm.
and that influenced my degrees in molecular microbiology and medical laboratory science. So not only did I get the training on the holistic side, I got the, MD Anderson Cancer Center, very conventional hematopathology training as well. So I saw it from both angles. And, I even sought to study with Robert Bradford before he died, with American Biologics back in the day. And he was the one that put out in the Townsend letter back in, I don't know, early 2000s, that he was observing parasitized leukocytes, what he believed was Borrelia burgdorferi. Right. I bring it to my PhD level microbiologists at the university, and they're like, "No, you can't see Borrelia in the blood like that." You could probably see some biofilm and
Mm-hmm.
L-forms in the blood. You're lucky to really see Babesia in the blood. So all those different
Mm-hmm.
tick-borne issues. But the issue is, you got somebody that went through a weekend course training in this technique, and they're running around making all sorts of erroneous claims. And I see it all the time, and that's why there's no validation to this technique, right?
Mm.
I personally, I don't announce it. I've been doing it for 22 years. I don't charge for it. I
Sure.
don't document on it. This is strictly research use only and education for me in my microscope, right?
Yep.
I just, if you want it, we do it. It allows me to take a deeper dive into things. And but in regards to the regulatory landscape, if you're going to use it as a diagnostic tool, it needs to be performed in a CLIA high complexity lab, right? And what you're able to kind of profess from it is, like, yeah, you could see mycoplasma. You will definitely see mycoplasma in cell wall deficient forms, right? And there's really good research from Lyda Matman from Yale University, who wrote a book called what is it? Cell wall deficient stealth pathogens, right? Very interesting. It ties into the whole Lyme world and everything else. And she passed
Mm-hmm.
away, a couple of years back, and also studied with Majid Ali, who's a Columbia trained pathologist. He has some very interesting theories about some of the observation. He actually did the immunohistochemical staining to look at different forms of fungus in the blood, the fungus amongus. So
Mm-hmm.
it's interesting, because then you go to like a infectious disease expert, and they're gonna be like, "Yo, if you got fungemia, you're about to die," right? You're like,
That's right.
that's it. But, the reality is, I believe this is seeding from the gut. So as there's such dysbiosis that's, overgrowing in the intestines, you will see what's called endotoxemia and shedding in the blood with these microbes in the blood, right? And those microbes actually go and they bind toll-like receptors 2 and 4 and a few others, and they actually program the NLRP3 inflammasome and lead to this low-grade smoldering inflammatory process, right? So inflammation, oxidation, ischemia, and immune dysregulation. Remember, those proteomic signatures are very common to see microscopically. So,
Mm-hmm.
there's no denying we could observe three well identifiable elements in the blood: red cells, white cells, and platelets. We could identify red blood cell size, shape, distribution, and morphology, right? We're able to identify if there's levels of micronutrient imbalances with anestecytosis. This is conventional hematology. If you're at blood cells too big, folic acid, B12; blood cell too small, iron, right? Hypersegmented neutrophils, B12, right? Sluggish white blood cells, taurine, right? These are well established in the literature, right? Um, and you see it. It's super cool, right? So
So fun.
it's in regards to those observations. They're definitely observations. I think some people take, a little bit too much liberty at making clinical associations to those morphologies in the blood. I never do. Or I
Yeah.
do in my mind. I just don't say it out loud because whatever, but the reality is, and then you can make all sorts of genetic associations there too in regards to, like what's your redox looking like, again, this is just terrain. So I use it as a qualitative cellular dynamic visualization used for research and education. It's non-diagnostic, it's non-anything, and we just have a conversation around it. So that's
Yeah.
how I use it, right? And I'm not trying to overstate, whatever, when it comes down to it.
Yeah, I mean, I think it's great. It's very much in alignment with what Dr. Tom would say. He's like, look, if you're looking around a room and you have a flashlight for your keys, we expand the visual field. We're like, oh, I'm going to get a picture over here, and that's some information. I'm going to get a picture over here, and that's some more information. And we get a bigger picture of the room. Not necessarily brings us to like a conclusion with a bow tied up on it. I think it's fascinating. Can I ask you, because you work with technology, is it valid to see something as an effect like the Rouleau effect, where we have a clumping of red blood cells and then put somebody on a pulsed electromagnetic field system and then see the voltage change in the body? Is that something you've experienced?
I've done that experiment before and after. I have a pulse PEMF bed in my office. I don't have the Beamer. I don't have the QRS. I want a QRS, so I think that's the next one I'm going to buy. But you will see a bit of a shift, right? But the thing is, I'm not trying to market it or publish that, but there are tremendous shifts in the blood that take place with, simple interventions. So with the Rouleau stacking, that goes back down to simple kind of redox chemistry when dealing with something called zeta potential. Are you familiar with zeta potential?
No.
So zeta,
No, educate me.
yeah, zeta potential refers to the electrostatic negative charge that is basically carried around every single red blood cell, right? And that zeta potential is actually lost with increasing cationic burden or positively charged particles, right? So that negative charge that helps the repelling force is gone and diminished with too much protein, too much salt, too much sugar, hydration, so on and so forth. And that's where I think this technique loses some of the credibility, because they're like, again, from a conventional hematology perspective, right? When you go and you do a peripheral blood smear in a hematology lab, you look at what's called the feathered edge, right? So leading up to the feather edge and how you prepare that slide, you need to look at the capillary distribution of the actual cover slip to the microscope slide. And some people are very selective with where they look at under the slide, and it's very manipulative and unethical and misguided, right? You need to look at the feathered edge of the slide and zones that aren't specifically distorted based on the fixation of the slide, because this is a non-stained, undenatured peripheral blood smear, right? So you're not doing the traditional technique microscopically where I wish I could just show it to you, where you take the slide, you hold it like this, and then you pull it across, and you lay it down, and then you stain it, and all that stuff. We're not doing that. You're taking a cover slip to the finger, putting it on the slide, looking at the capillary distribution, right? And then you're going to the feathered edge, right? Where it's less agglutinated, less rouleauic in nature. But that's one of the manipulating techniques that some of these folks with the microscope do. They're like, oh, look at this shit. It's all bad. You need this, you need that. Here, buy this, buy that. Right. And that's where this technique, it's lost its credibility. So, again, for me, I'm not trying to sell you anything. I'm not trying to whatever. I want to get the real clean picture of what's going on. Is there real rouleau there? Because again, keep in mind, that could be associated with M spike proteins, not COVID, right? But like multiple myeloma is a hallmark for that kind of protein bump, right? And the calcium in the system due to osteolytic lesions, mobilizing that. And again, what did I say about zeta potential loss due to cationic charge? Calcium is cation,
Mm-hmm.
and that could cause too much calcium, cause that agglutination. So it's looking at the redox chemistry, right, is very important in this entire equation, with correlating some of the steps that you see qualitatively, microscopically, to the actual chemistry and physiology. I hope that any of that made sense. Did any of that make sense?
It did, yeah.
All right,
Yeah,
cool.
it's very, very helpful.
Yeah.
Well, it's just, again, you spend so much time in the space. Sometimes you hear just things regurgitated, and you're like, well, is that really true? Because I've held that belief for like 10 years. Is that a valid experience I had with this practitioner and that practitioner? And it's just, I think it's always good to like try to like wipe your bias away,
Yeah.
which I'm always attempting to do on this podcast. And more than anything, try to remove some of the marketing for people.
Yeah. Yeah.
And that's why that's why I have to have conversations with people in clinical practice, people seeing outliers, people seeing the difficult, challenging cases. I would love to ask you, what are like 3 of the top diagnostic tests you love to have from people? And if you're open, even like some of like the company, like this is the genetics test I like, or this is the stool diagnostic that I really love. This is the micronutrient panel that I'm really a fan of for whatever reason.
Yeah. That's a great question, because limiting it down to 3, I gotta say 5, right?
You can do 5.
Because I've done iterations of this. And my core 5 that are going to be non-negotiable coming to see me is going to be the core 5 for my multiomics: genomics, proteomics, metabolomics, exposomics, and microbiomics, right? Because those provide me a window of understanding and connecting of dots that I just need. And it also depends on what the symptomatic presentation is, right? So like for some people, you might not need a microbiome profile, but you'll be surprised, despite no symptomatic deviation from norm and baseline, completely, in my questionnaire, normal digestive function, right? You probe a little bit deeper, and there's still some issues, that, you want to rectify, whether it's EPX protein associated with histamine intolerance based on some of the foods you're eating. It might not be manifesting directly in something observable, but below the scenes, there's a low-grade smoldering inflammatory process taking place digestively, right? Based on some of the histamine-loaded foods. Or low secretory IgA in the gut, which could be associated with immunological compromise, and how do we bolster that, and looking at other things, maybe low grade, leaky gut, how many times I've picked up leaky gut, both microscopically, and through a microbiome test, right? So it's those little things that, very interesting. So in regards to the different companies that I like and would endorse, there's always cost associations with it, right? And the actual utility and benefit to the patient. And, there's a handful of genomic testing companies. I don't want to be, with my position with the Board of Precision Medicine, I want to make maintaining a non-biased kind of representation. But I could say, hey, clinically, the companies that I like and I've used, I really like Self-Decode. Believe it or not, I think their platform is fantastic. I think Joe is an interesting dude, but, and the platform he's put together, with his CMO, Puya Yazdi, fantastic guys, really knowledgeable for the pursuit of self-actualization and understanding. I really like New Amsterdam Genomics in regard to whole, complete exonal sequencing, right? I really like Myome, right, for their polygenic risk scores as well. I like Intellect's DNA as well, Sharon Cohen's company. I like I really like Bob Miller. I think he's fantastic, with methyl genetic nutrition. I have respect for, 3x4, as a diagnostic company as well. And it's like, look, some patients come to me with some of these profiles. Some are more limited than others in the ability to kind of extrapolate kind of key bioregulatory pathways or whatever it is for me. And my default is, right now, Promix Edge, which is self-decode. I think
Hmm.
for me, I've gone through so many, and I like that one the most.
Most practitioners, I ask a lot of practitioners this. Most people with biological medicine slant pick self-decode.
Yeah, yeah,
That's been the main. I've asked 3 people in a row.
yeah, yeah. And I'm very look. I like those guys. I'm very close. Puya is part of my CTO for the American Board of Precision Medicine. So I think he has a profound fund of knowledge that is very important in this field, because when you speak to mainstream conventional geneticists, I think it's I don't think it translates. I think sometimes, they're just so hyper focused on like these Mendelian Punnett squares that it's just like, hey man, there's a whole world of other clinical application with polygenic risk scores that we could be looking at, as it relates to dyslipidemia, cardiometabolic issues, like LP little a, that tracks 98% of the time. If you have a gene for LP little a, you might have those elevations, on your lipid profile. Not to mention, some of the pharmacogenetic applications as well, knowing, kind of predicting, if needed, drug or medication, how somebody's going to respond to it. I'm not saying that's the holy grail, but it's definitely a tool that we could use in our kit to make a personalized decision about, selecting a medication. So, with patients, I'm always like, hey man, this is your data. We're going to revert back to this all the freaking time. It's not a one time, like, this is your blueprint and this is your death sentence. Now go, right? No, it's like, how to use this? How do we look under the hood? Where do we need to pay attention to? What areas do we need supporting? And that's when we work our way up the molecular ladder and look at proteomics, metabolomics, and a few others. Metabolomic testing, I really like Therium. Proteomic testing, I really like Molecular U. I think Robert Frazier from Molecular U is a brilliant clinician. I'm sorry, PhD researcher / borderline clinician. I think Paneej Jaspi from Therium is one of the brightest metabolomists that I've ever had the privilege of speaking with. And guess what? All those guys are on my board. I'm trying to find the best technologies, the best people in the field to pull them together so that we could all play nicely in the sandbox and bring forth, the future of precision medicine, and that's it. Exposomics, I've got, different opinions about different companies. Mosaic's out there, Vibrant Wellness is out there. So there's just different ways of really unpacking that. Provoked urine testing versus unprovoked, for data collection on heavy metals. There's just different arguments depending on the individual.
I'll tell you, I just did a Vibrant Total Talk panel.
Oh yeah, that's right. Yeah.
And I had done one before.
Yeah.
And I did one after our sauna and a Flowpresso. I collected urine the next morning.
Oh geez.
And it was shocking.
Yeah.
Mold, gliotoxins, and 3 or 4 pesticides at like the 95th percentile.
Yeah.
And I was, I've said this a couple times on the show that I had done other environmental burden tests and they were clean, but after doing those 2 therapies, I was like, holy cow. And the way I live.
Yeah, I do.
It's pretty wild. I was like, man, I've been at this like 15 years. Are you kidding me? But it was so empowering. I was like, again, it's never going to be a sprint. This is just a lifestyle. Nothing really changes. I keep doing my thing, take a little bit of a binder, keep sweating 3 to 4 times a week, do a Flowpresso once a week, eat clean, support my gut, support my liver, be in joy. Like you said, life's really short. Try to have a rock star of a good time. And just try to have more fun with it.
That's it. Have fun.
Yeah, try to have more fun with it, which I do. I have a good time. I love being alive. It's great.
I love seeing you. Every time I see you, it's always a good time. Whether we go to another clinic and get IVs, or I don't know. I think I saw you at the Steve Aoki at the Biohacker Conference performance. Were you at that?
No, but I that was a great example of a show where, you're at an event with 4,000 people,
Yeah.
and you're putting you know what it's like to wrap one person in Flowpresso. It's like
Oh
it's
yeah.
a you're committed. You're with them. It's not just like slap them on and push go. There's a facilitation process. We were wrapping 100 people a day
Oh my goodness.
for 3 days.
Yeah.
So
I got a couple wraps in with you too.
yeah, you did. And so by the end of the 3 days, you're just like, dude, I'm like, the only way I can show up tomorrow the way I did today is I'm going to bed. I'm
Oh
going to
yeah.
eat really clean. I'm going to do some sub-Q NAD and some N-acetylsalanc. And, I got my ways to get through the shows these days that I feel, because I want to be the best version of myself for all those people.
Mm.
Yeah.
That's a thing. You got to kind of recharge and be able to create that balance, especially when it's so energetically depleting. When you're doing so much of that, every time I see you, you're always on the go.
Yeah.
And that's it. It's knowing when you can actually kind of unplug and let loose a little bit. But again, I'm a conference junkie. I've been going to these things. I've been going to A4M since I was an undergrad. So over oh gosh, I don't want to date myself, but almost 20 years now. And it's again, before even starting med school, I was already thinking, I'm like, all right, these doctors, they know. They're way ahead of the curve compared to, dare I say, I don't want to marginalize anybody else's work. All my friends in the space that are in the trenches and family medicine and healthcare, they're doing the best that they can based on the institutional rules, regulations, limitations, and scope. And I will make the last argument that I do think that when you really start looking at drug therapy and longevity, that it's very interesting to see that some of these common medications that are being prescribed, metformin, losartan, and dare I even say statins, are touted to be longevity promoting agents. I know that's a very polarizing concept, but if you were to actually go to the literature, they're actually augmenting and neutralizing some of these hallmarks of aging. The TAME trial targeting aging with metformin is a real study that is like, oh man, metformin has some benefits. So, arguably, primary care doctors are longevity physicians in the trenches dispensing arguably some of the most, impressive forms of anti-aging drugs. I don't know.
Yeah.
That's one way of seeing it. But how do you dial in the other side of the equation with the dietary lifestyle and biohacking? And that's you got to have a passion for it. You got to have a passion to build that routine and do the things that you do. Go outside and shower naked and hug your puppy and do all the fun stuff.
Yeah.
So yeah, man.
Yeah. Jump in the cold plunge when nobody's around watching you. I do feel that, the other idea I've been playing with is like this, the body doesn't lie. This protein expression, like if all the things I were doing were bad, right? I've got my own Dunedin aging pace study. It's called My High School Class.
Mm-hmm.
So if I go back and I can look at the other 47-year-olds and I'm like, I'm doing something right. I've got this own little pod because the skin is a great expression of the proteome. My eyes, the health of my teeth, my mobility, my cognitive function, word recall. I've got all these little things that I have my little touch points that I know if some of the things that I'm engaging in, be it the lifestyle or the diagnostic testing or some of the oxidative therapies or drinking hydrogen water every day, theoretically they're showing up as this expression that is Freddie that's like working for me. So that's the other thing that's really interesting in our space, because you'll see people touting this longevity something and I'm like, God, you look like death.
Yeah.
You don't look rested, or you're not kidding. Okay, there's been some cutting happening here. It's not this is not the lifestyle. Not to shame or judge that, but that's like, another thing. It's like, we do have this body that is like our evidentiary proof of the work.
Yeah, and I gotta say, like, when you're in the trenches, and you see all these influencers that have, they're able to monetize things differently. They have different streams of income that could afford that type of lifestyle. I love that. Good for them.
Hmm.
But when you're like, still seeing patients, you're still lecturing, whatever it is, or you're working your job, it becomes difficult when you have a family. You know what the greatest threat to longevity is? Having kids. I hate to say
Mm.
it, like early on, having kids, the sleep disruption, just the stress levels and everything associated with that. I gotta say, it's more challenging than going through residency and being sleep deprived for a month.
Mm.
So it's just very interesting to see, and I can only commend my colleagues that did residency and had kids and was pregnant and delivered during. They are the strongest women I know, and all I could say is it's just very interesting because there's so many confounding variables that threaten our potential longevity, right? I have,
Yeah.
we were just sharing, I have a 2.5-year-old at the time of this recording, and I have another one on the way in like less than a month. I'm not going to sleep for the next year, too, and it's just like, it sucks because I
Yeah.
love my sleep. I love tracking my sleep. I love the data points that we get from that and trying to biohack it. But I'm afraid to even take a melatonin, to try to get deeper sleep because it's going to be disrupted. I already know it, So it's like, how do you build in kind of these safeguards to
Mm.
optimize some of these potential threats to your routine, rhythm and routine with biohacking? And it just comes
Yeah.
with time, For me, it's this phase of life, and
Yeah.
we.
Well, and to your point, that is part of our biology to
Mhm.
have a child and be through this wave of disruption, whether it's 2, 3, however many years it is. And people do it. Like you said, they do it and they come out the other side and you're like, probably, how did you do that? And the person's probably like, I have no idea,
Yeah.
but, but I'm here and it's good now.
Yeah. Yeah. Well, go on.
I know it's an hour. I know you're at a practice. I know you're in
Yeah.
practice. I want to be mindful of our time and our hour. We will definitely do this again
Oh, I loved it. Yeah.
because there's so many things that we could talk about and just explore.
Yeah.
And again, I think the value for me is I want people to probably going to listen to this podcast. A lot of consumers, a lot of people seeking, they want more out of their body. And to not be overwhelmed if you didn't grasp every single context that we're putting on bodies, but the idea that there are clinics like yours doing this at a very high level. It is truly precision medicine.
Yeah.
My question for you is, can people see you without coming to Maryland or
Oh yeah,
do
dude. I see people all
yeah,
over the world, man. I'm licensed in 40 something states, number one. The only request is patients in New York need to come and see me in person. First, that's like the one state that's like not present.
New York,
Yeah, so I'm licensed in New
always.
York, but the continuity could be delivered virtually thereafter. So I see patients all over the world. Germany, Switzerland, France. People fly in from all over the world to come and see me. I got somebody coming in tomorrow from Portugal, and I have a doc flying in tomorrow from Boston to be seen here. So it's just we have fun, and yeah, that's it. We have fun with what we do.
Vaughn, where do people go just to explore if they want to check out your site?
Yeah, so I got a couple of websites. The main website is IFHO, Institute for Human Optimization.org, ifho.org. I also have the ABOPM, for the Board of Precision Medicine.org. So the ABOPM.org. I have my personal website. If they just Google my name, we'll find some stuff there, some good, some bad, and some indifferent, whatever. And but yeah, I'm around, Instagram and whatever. I'm just not that active on it. I'm just so busy with like teaching at
Oh, good.
university and
Please.
stuff. It's hard to keep up with all those different moving parts.
Yeah, don't do that. Don't do that. You don't need to do
Yeah,
that.
yeah.
You got plenty on your plate.
Yeah, yeah.
That's probably filling your cup a lot in greater capacity.
Oh yeah, yeah. Well, right now my biggest goal is leading that revolution in healthcare, with adopting, this new paradigm shift towards a precision medicine approach and being able to democratize the testing, getting it covered by insurance, so that we could have access. Everybody could have access to this type of information. That's not going to break the bank. That's my goal.
Yeah, beautiful. That's so needed.
Yeah.
That's so needed. Well, I'm honored to know you. Happy that you are charging forward even with a baby on the way.
Oh yeah.
And just let me know how I can support you in the future.
We have a conference. Our first conference is going to be in San Diego, October 9th.
Mhm.
And it's going to be kind of piggybacking off the Health Information Exchange Conference with Jeremy from Biocanic. Yeah,
Mhm.
but we're doing a one-day event just as a lead for the American Board of Precision Medicine. And then we're also having a giant roundtable at Illumina headquarters in La Jolla the day before. So, if people are interested, they could take that event. It's going to be limited to 100 folks,
Mhm.
and got that event that's coming up in October.
Amazing. And I'll see you at A4M for sure.
Yeah, I should be there. Yeah.
Great.
Awesome. Yeah, I'm doing
Great.
a talk at A4M Boston on Synalytics in September. I'll try to make it to Vegas in December, but I'll have a newborn. It's gonna be
Yeah,
as long as I'm allowed to go, I'll be there.
I love it.
Nice.
I love it. Thank you for being a guest,
Yeah,
Anil.
man.
Such a treat.
Great seeing you, buddy.
Good
Awesome.
seeing you. Big love.
Thank you.